Hello, and welcome to this episode of A Cancer Conversation with the Georgia Cancer Center at Augusta University. My name is Chris Curry, and I am your host for this podcast series. Today, we will be talking about ovarian cancer. Our guest for this conversation is Dr. Bunja Rungran. Dr. Rungran is the chief of the section of gynecology oncology at the Georgia Cancer Center and the Medical College of Georgia here at Augusta University. Dr. Rungran, thank you for sitting down with me for this conversation about ovarian cancer. I'm excited to have you join me for this discussion because I know we have a lot of really good information to share with people that are watching and listening. First, though, I always like giving my guests the opportunity to share a little bit of information about them. I want people to be able to learn about you, who you are. So talk to me about your choice to pursue a career in healthcare and focusing around cancer care, cancer research.
Well, first of all, thanks for having me.
Absolutely.
Happy to be here today. So I always wanted to do medicine from kindergarten. I think I drew that I wanted to be a doctor, you know.
Wow.
So I've always known I wanted to do this. I love helping people.
Okay.
But my course in oncology is a little bit different than, say, the medical oncologist you talk to or the surgical oncologist, because for GYN oncology, we do training in OBGYN first, so 4 years of delivering babies.
Oh, wow.
And then we specialize in oncology for an additional 3 years after that. So people always ask me, why would you give up delivering babies, something that seems so joyous to take care of cancer instead? And, for me, if something goes bad with something that's supposed to be so joyous, like a pregnancy or a delivery, it's just so devastating. Versus when people come to me, they already expect the worst. And so any hope, any time, any meaningful quality of life I can give them is a win. And that makes me happy to be able to help them. So that's why I'm really passionate about oncology.
That's awesome. So for those who don't know, September is Ovarian Cancer Awareness Month, and we're recording this episode in September. What can you share about any signs or symptoms women should be watching for that could point to an ovarian cancer diagnosis?
Ovarian cancer is usually called the silent cancer, and that's because the symptoms are really, really vague. And because they're so vague, it tends to get diagnosed a little bit later. It's not uncommon for me to see someone that gets referred to me from their primary care doctor who was doing a workup for a little while, or they got referred to a GI doctor because they were having some abdominal symptoms that were kind of vague and they thought it might be related to that. Sometimes they get sent to me from gynecology because they feel a mass on exam, but that's not the norm.
Okay.
So the big symptoms I tell people to look out for, one is bloating. So you feel like you may not be eating much, but your abdomen keeps getting bigger. And that's because it may be a mass that's growing inside, but it may be fluid that's accumulating inside, which can also go along with ovarian cancer. The second symptom that I tell people to look out for is something called early satiety, so feeling full after just a couple of bites of food. And even though, again, you're not eating much, your belly keeps getting bigger. And that's a big symptom of ovarian cancer as well. And not just something that you ate and you feel a little bit bloated, something that's really persisting over time.
Okay.
Pelvic pain can sometimes be a symptom of it, but it's a less common one because usually as a mass on the ovary starts growing, it starts moving up out of the pelvic area and makes the belly feel bigger rather than staying in the pelvis and causing pain and pressure there.
Okay. So I know we always talk about knowing your body, getting your physicals, so it's really important to follow those sorts of steps with a cancer like ovarian cancer.
Mm-hmm. Especially with ovarian cancer. I mean, you really have to be your own best advocate for it because the symptoms are so vague. And, sometimes I have a lot of patients who just cast off the symptoms as, it's just something I ate or I just don't feel well today. But really knowing what's not right for your body and really seeking the care. And if you get an answer that doesn't seem like they're finding anything, keep asking the next doctor. And oftentimes I see people with an ovarian cancer diagnosis at stage 3 or 4 because they've been through a few different doctors because they had these really vague symptoms until it was obvious what was going on.
Mm-hmm. Okay. Who is at high risk for developing ovarian cancer? Who should really, really be paying attention to their bodies and to the things going on, like you were talking about?
Well, the most common age group for ovarian cancer are women who have already gone through menopause, usually in their early 60s. So definitely any of those symptoms we talked about in that age range, 60s or later, that's not normal, and you should definitely see your doctor about it. Abnormal bleeding doesn't usually go along with ovarian cancer, but if you're having other pelvic pain or symptoms that aren't going away, it's important to see your doctor about that. And then family history is a big, big risk factor for ovarian cancer. We think that up to 25% of ovarian cancer can be genetically related, meaning there's something that runs in your family that's inherited through your genes that made you more likely to get it. So if you've got family members that have ovarian cancer, you should definitely get tested. If you think back, several years back, Angelina Jolie had a family member with ovarian cancer, got testing herself, and she was positive for the BRCA gene and really brought that to light. And so having that family history, it's important to let your doctor know if any cancers run in your family.
Do you hear a lot of people sharing that story about Angelina or other celebrities or other high-profile people when they come to see you? Like, I'm thinking about somebody who maybe heard her story or someone else's story, started asking questions, paying attention to their body, and then eventually through testing and various doctor visits, they come see you. Do you see that happen?
A little less frequently now, but I finished my training right around the time that she got her testing and that was discovered. And it was also quite expensive for genetic testing back at that time, but after she came out and disclosed that, there was all this popular public demand for more affordable genetic testing, and it changed some of the laws. And so around that time, I had more and more people coming in seeking genetic testing. Now it's become more of a norm. It's much easier to get genetic testing, but around that time, definitely so.
And talk to me about working with our hereditary cancer clinic. We've interviewed Dr. John Henson before. He's the director of that clinic. What is your interaction with him and his team like for your patients with this great need for genetic testing?
Well, all ovarian cancer patients should undergo genetic testing. It makes a difference not only for their risk of other cancers, but their family's risk of cancers, but also for the treatment of ovarian cancer. And so Dr. Henson and his group with the Hereditary Cancer Clinic have really been great allies for us with really making sure that all of our patients are getting tested. We can actually test people in the office when we meet them at the beginning of their diagnosis. And so we can find out very early on if they have a genetic mutation or not that made them more likely to get ovarian cancer that would then affect their treatment options. And then Dr. Henson's office also does a great job of testing the other family members. One thing that I do tell my patients, if they do come up with a positive mutation, if they are found to have a genetic mutation, and they're going to tell the rest of their family members, is if the other family members are going to get tested, there are healthcare laws that protect them from being able to still get healthcare insurance, but there are not laws that protect them from being able to get life insurance or disability. And so I usually tell them, again, the average age of ovarian cancer is in the early 60s, so their kids sometimes don't have life or disability insurance, so I tell them they should seek that out before they get the genetic testing done.
That's a good point. What difference does, and I think I know the answer, but I want you to talk about it. What difference does knowing the type or the genetic mutations of ovarian cancer have when it comes to treatment?
So for treatment for ovarian cancer, everyone gets a combination of surgery and chemotherapy. And then after that, most patients are candidates for something called maintenance therapy. So when you get into remission after you finish the initial treatment, going on a medication that helps maintain that remission, being cancer-free. I explain to patients, just like if you had high blood pressure and you went on a medication to control the blood pressure afterwards. And so if you have a genetic mutation, there are certain drugs that work better for you for maintenance versus someone that doesn't have a genetic mutation.
Okay. What does it mean if a cancer is stage 3, stage 4, stage 2? What does that mean in terms of the patient's care, the patient's expectation?
So the stage means how much has the cancer spread. And so ideally, we try to find cancers at a stage 1 because stage 1 means it's just in the organ where it started. That's going to have the best prognosis for everyone. And like we talked about with ovarian cancer, unfortunately, that's not the norm for ovarian cancer. If it spreads to the tissues that are nearby, that's stage 2, so in the pelvis, and you in all the diagrams, you see the pictures where the ovaries are just hanging off the edge of the uterus, but in reality, they're just free floating in that pelvic cavity.
Okay.
It's still attached to the uterus, but still touching all of those tissues. So if something starts on the surface of the ovary, it pretty quickly spreads to other areas. And for stage 3, which is the most common stage where we see this, it's spread inside the lining of the belly. My partner, Dr. Johnson, describes it to patients, and I think this makes a lot of sense to them. If you throw a handful of sand, wherever those little sand grains land, those are the tumor cells, and that's where they start growing.
Okay.
And since the ovaries are open to the entire belly cavity, they pretty quickly spread throughout the whole belly cavity to be a stage 3. And when it becomes stage 3, that's when you start getting the fluid in the belly, the bloating, the difficulty eating, and that's when you finally have enough symptoms to get checked out. Stage 4 is really not that common for ovarian cancer like it is for some other types of cancer. Ovarian cancer doesn't usually like to spread outside of the belly cavity. It definitely does not like to spread inside the lungs or to the brain or to the bone. It can sometimes spread into the space around the lungs and cause some fluid there, and that fluid would make you a stage 4.
Now, I know we talked about genetic testing here at the Hereditary Cancer Clinic at the Georgia Cancer Center, but there are lots of different types of at-home genetic testing. I'm thinking of 23andMe, there's Ancestry.com, there's lots of at-home sort of genetic tests these days. Can women use those to test for genetic mutations related to ovarian cancer? Is there any information that they're going to get from that test that would be helpful?
They're not great tests for looking at the genes that predispose you to cancer. We think that there's about 70 genes now that are responsible for cancers, and those genes are not usually covered in those at-home tests. Okay. But the testing that we do have here at the Cancer Center through the Hereditary Cancer Clinic does cover all of those genes. Insurance coverage has been great for that, and there's not the same stigma for it that there used to be. So it's definitely best if you've got a family history, it's best to ask about getting the cancer genetic testing. That will give you the most information.
Okay. Talk about the treatment options. Talk about the chemo. Talk about the surgery. What does that look like? What should someone expect, in terms of treatment? Mm-hmm.
So ovarian cancer is usually diagnosed at a later stage, but it responds really well for treatment. So when I meet a patient with ovarian cancer and I tell them that they have stage 3 usually, I do tell them that there's an 80 to 90% chance I can get them into a full remission because it does respond so well.
That's awesome.
Which is great. And then the flip side of that is without any maintenance treatment, it's got an 80% chance of coming back, but it continues to respond to treatments. So ovarian cancer becomes more of a chronic disease versus some of the other cancers where when you get that cancer, there's not a lot they can do in terms of treatment if it comes back. So the initial treatment for ovarian cancer involves some combination of surgery to remove the organs that are affected by the cancer and chemotherapy. And depending on where the cancer is spread to, will determine which order we do that in. So sometimes you get the surgery first, followed by chemo afterwards. Sometimes you get the chemo first, then a surgery in between, and then a little bit more chemo afterwards. Usually the chemotherapy takes about 6 months to complete, and then after that we would do maintenance therapy. And the maintenance therapy depends on markers that are on the surface of the tumor, markers that are in the genetic testing that we would do, and that medication's oftentimes given for 2 to 3 years afterwards, usually in pill form, which is a little bit easier to do for the long term.
Yes.
But the biggest chance of it coming back is in the first couple of years, and so that's the point of trying to get through that time where you're at the biggest risk of it recurring.
Is that pill an everyday pill, or does it depend on the type of medication?
It is an everyday pill,
Okay.
but it's pretty well tolerated. People do very well with it when they take it.
So, Dr. Rungram, one thing that I wanted to ask you about, we talk about Angelina Jolie, and one of the things that she talked about with her story was having a double mastectomy, having her breast removed to, reduce her risk as much as she could for breast cancer. We talk about the ovarian cancer happening in younger or older women, but their younger daughters and granddaughters and whatnot potentially getting that genetic testing with the hereditary cancer clinic, should they consider having their ovaries removed, and what does that do for their chance of having children later in life? Talking about freezing eggs so that if they want to have children later on in life.
So I always tell patients knowledge is power. And so getting the genetic testing is important for them with their cancer diagnosis, but it's also so important for their family, because that's oftentimes they're more concerned about what's going on with their family than they are with themselves when they come to see me. And so if they test positive for a genetic mutation, depending on which one it is, some of them are higher risk than others, like the BRCA mutation that Angelina Jolie has is much higher risk than some of the others that are maybe at a lower risk. That determines when you should get surgery to remove your ovaries, but you should get surgery to remove your ovaries if you're at high risk. That age is usually, the earliest is for BRCA1, and that age is 35 to 40 in that range to have their ovaries removed. And so once people find out they have the genetic mutation, again, I have several families that I follow with these mutations. I have some people as young as 19 to 20 that I follow in a family. We talk about, need to have kids by a certain time, ideally by the age of 35, and be done. And if you're not done by that point, then we need to talk about harvesting eggs, and we could keep your uterus in place, and they could get a donor, or not a donor egg, but they could get in vitro fertilization using their own eggs at a later date if it needs to be after the age of 35. Some of the other mutations you can wait until 45 to 50 to remove the ovaries, and a lot of people are done with the childbearing by that point. Yeah. If they decide to do, ovarian, like ovary harvesting and freezing, the oncofertility specialist can actually do DNA testing on the eggs to see which eggs are affected by the genetic mutations and which ones are not.
That's awesome.
So then it would then break that family out of the cycle potentially, because you have a 50-50 chance of inheriting it. So not all of their eggs are going to have the genetic mutation, so they can select that out ahead of time if that's something they chose to do.
That's awesome. So when I was doing some research for this episode, I read information about fibroids and ovarian cysts. Are those related to ovarian cancer?
That's a great question. So fibroids are not. Fibroids are benign or non-cancerous muscle tumors inside the uterus, and so they're really common. A lot of women have them and don't even realize they have them, but they do not increase your risk of ovarian cancer. Ovarian cysts can sometimes. So when you're still premenopausal and having regular menstrual cycles, the ovaries routinely make cysts, and those tend to go away along with your monthly cycle. However, if you've got a cyst that's continuing to persist, and you may notice that from pelvic pain or pressure, then that, or when your doctor sees you and does an exam, that would maybe be a red flag for it to get checked out. Probably isn't cancer in a younger age, but still worth getting checked out. A cyst that's still present as you're going into menopause or beyond menopause should always be checked out, because it may not always be cancerous, but it's still worthwhile getting checked out, especially if it continues to enlarge.
Let's talk about the future of ovarian cancer care now. We know that medicine is always changing. You mentioned those 70 genes that we can test for now. What do you expect in the next 5 to 10 years in terms of just general care? What sort of research is going on right now that we can share with people about sort of the future of ovarian cancer care?
Mm-hmm. Even in the last few years, there have been so many updates for ovarian cancer care. When I was in training, there were like 2 drugs that we used for everything.
Okay.
And now there's so many more options that we have to where it's, like I said, it's got a high chance of coming back. Mm-hmm. But so it's not uncommon for me to have a patient who's been on 7 or 8 different types of chemotherapy and still has good quality of life and is spending time with their family, because there's so many different drugs that we can use for ovarian cancer if it comes back. And so a lot of it is shifted towards what we call personalized medicine, where we check the surface markers on their tumor when we take it out at surgery. And depending on what markers are there, we have certain drugs that are targeted just to that marker that have a much higher chance in working in that patient than they would in another patient that doesn't have those markers. The new area where we're starting to look at for ovarian cancer that's already been shown to have tremendous effects in cervical cancer and in uterine cancer is looking at immunotherapy. And so using drugs that help your body's own immune system fight off the cancer. Starting to show some promise for ovarian cancer, but not as much as it has for cervical and endometrial cancer. But people are continuing to still look at that and looking at other targets on the surface of ovarian cancer tumors to find these targeted therapies rather than just giving blanket chemotherapy to everyone.
Dr. Ovarian, I know that we recently, in the last 6 or so months, hired a surgical oncologist who specializes in the high-PEC chemotherapy procedure. Does that work for ovarian cancer?
That's a great question. It works sometimes for ovarian cancer. You have to have select candidates for it. What it is it's heated chemotherapy inside the abdominal cavity at the time of surgery. And so right now, the clinical trial data shows that if you give chemotherapy first to shrink down some of those smaller cancer spots along the lining of the abdomen where the ovarian cancer will spread, and then you do a surgery and give the heated chemotherapy in the belly at the time of that surgery, then it can improve survival for some of those patients if they're the right candidate. It's very specific who benefits from it, but it's worthwhile to have a conversation with your doctor to see if you would be a candidate for it.
Well, Dr. Ovarian, I appreciate you joining me today for this conversation. I feel like we've covered a lot of really helpful information for people who may be watching and listening to this episode. So thank you for taking time out of your schedule. I know y'all are always very busy, but I appreciate so much having opportunities to interview, talk with physicians and nurses, et cetera, like yourself. So thank you for sitting down with me today. I appreciate it.
Thank you so much for having me today and for bringing light to something I'm clearly passionate about.
Absolutely. We can hear it in your voice, so that's great. And I always enjoy working with you, so that makes this even more enjoyable. So thank you very much.
Thank you.
And thank you all for watching and listening to a cancer conversation with the Georgia Cancer Center here at Augusta University. We appreciate your time. If you have any questions or follow-up information you would like to learn about ovarian cancer, you are always welcome to send us an email. The email address is cancer@augusta.edu, and we would be more than happy to forward those questions along to you, Dr. Rungaran, and get those answers and share them with you. Remember to like or subscribe to A Cancer Conversation. You can find it wherever you get your podcast, and we will see you on the next one.